Hi, I'm Dr. Randy Martin with Northwestern Medicine's Bloom Cardiovascular Institute, and we're here today talking about atrial fibrillation, which is a major health problem, as we're going to learn in just a minute. But we're also here at the CAST AF meeting, which is Northwestern Medicine's really new innovative program that has brought together maybe 300 participants to listen to world experts talk about new therapies for atrial fibrillation, catheter and surgical therapies, and I'm pleased to be joined by one of the course co-directors, Brad Knight. Brad, congratulations on this course.
Thanks, Randy.
So Brad is not only the co-director of this course, but he's also professor of medicine and the medical director of the Center for Heart Rhythm. Brad, atrial fibrillation, as I said, has lots of bad consequences. It's not only increasing in frequency, but it has some serious consequences. Tell me a little bit about those.
Well, one of the biggest concerns is stroke. When patients have atrial fibrillation, they're at an increased risk of stroke, and the mechanism is atrial fibrillation causing stasis of blood flow and clots that form in the atrium that, if they embolize or leave the heart, can cause a stroke if they go to the brain.
And there's all of us that are in cardiology know about the left atrial appendage, but that's the site of where most of these thrombi form?
Most of them, a great majority. Probably 90% of the clots that form, that leave, that causes stroke in patients with AFib come from the left atrial appendage.
I know if you look back at patients who have had ischemic strokes and they're over the age of 60 or even 80, that up to 40% of them have a history of AFib. So how do we, I know how we do. I'm going to ask you, what are the ways that we could prevent stroke in these patients who have AFib?
Well, we look at patients who have additional risk factors for stroke, which are most patients who are older, have hypertension, diabetes, or other comorbidities. And most of those patients have an indication for oral anticoagulation. So the current standard therapy is blood thinners to prevent clots from forming and causing a stroke.
Those come, we know, with their own risk, their own inherent risk, and oftentimes I know patients and even relatives don't take them appropriately. Isn't that a big issue?
No, those are both good points. The formerly used drug, warfarin or Coumadin, had a long track record but had a lot of limitations. There's these newer oral anticoagulants that are really taking over and have been well adopted and been proven to be safer and probably better. But still, even with those drugs, the adoption rate for patients that are started on them, many patients have a discontinuation rate of about 30% at 3 years.
Brad, if the left atrial appendage is the culprit of where a lot of these form, and patients can't or won't take anticoagulants, that's where this site-specific therapy of left atrial appendage closure comes in. Tell me a little bit about that.
Well, the concept is if you can remove the left atrial appendage from the blood pool and isolate it from the left atrium, that you can prevent any clots that might form there embolizing. So you can put in a plug, a left atrial occlusion plug device. The Watchman device is an FDA-approved device to do that. You can surgically remove it, staple it, ligate it. You can put in a clip. So there's many techniques, but the principle is to remove the left atrial appendage as a potential source of clot.
And just for clarification, you and I know this, but some of the viewers might not. To do it without a surgical approach is really with the plug technology. Is that right?
Right. So there's great surgical techniques, but they have their own morbidity associated with open surgery. So the developments really are percutaneous techniques. As I mentioned, there's a Watchman plug. There's other devices that have been already through clinical trials, and there's some hope that we will continue to evolve what is a logical solution to better and safer plugs.
Who would be the ideal candidate, or who is the candidate for left atrial appendage closure?
Well, the reimbursement guidelines and all the data really focus on a particular group of patients. They're patients who are at high risk, and the current Medicare guidelines that would reimburse include patients who have a CHA2DS2-VASc score over 3, so have a high risk. And the language is very clear that they have to have an indication for anticoagulation and can tolerate anticoagulation, but have a reasonable reason to get off anticoagulation. So in general, we're looking for patients that have relative contraindications to long-term anticoagulation.
But you mentioned the caveat in there that on the directions, they have to be able to take it. So do they? Obviously, if you put in a plug, a Watchman device or something like that, they have to be on short-term oral anticoagulation?
The data that led to approval and what most people practice is to anticoagulate for at least 45 days after implant, and then they have another transesophageal echo to look for complete closure. And the concept is it takes some time to endothelialize and to completely seal off. And at that point, if there's no flow into the appendage, they can be switched to dual antiplatelet therapy.
If a patient's going to have this done, and again, you and I know this,
Yeah.
but some viewers might not, this is not done by a catheter technique, percutaneous. They're not under general anesthesia or anything like that. They have conscious sedation generally, is that right?
Generally, no. Generally, we guide this with a transesophageal echo.
Okay. Okay.
That's really the part of the procedure that requires them to be under general anesthesia. At least in North America, most patients are under general anesthesia. We're trying to come up with ways to eliminate that need for using the transesophageal echo, or TEE, for guidance.
Right.
That might eliminate the need for anesthesia. But it's certainly not open heart surgery, and the anesthetic
Correct.
is very brief.
That's what I was really getting at. What's the efficacy of these in preventing ischemic strokes?
Well, the efficacy compared to warfarin is comparable. I tell patients that you're basically trading risks, and that you're taking a little bit of an increased procedural risk up front to eliminate the long-term risks downstream for many, many years. And the real difference is that if you can get these patients off anticoagulation compared to oral anticoagulation, or at least in the trials with warfarin, that you're greatly reducing the risk of hemorrhagic stroke. So on balance, you're reducing the risk of stroke because you're eliminating the cause of intracranial bleeds.
Are generally the safety profile of these is good?
Yeah. The studies have shown that with experience and some newer iterations of the device, there's been a great reduction in procedural complications. All patients that have this done in the United States are entered in a registry. The preliminary data from these registries also looks like in the real world experience, the complication rates such as tamponade or stroke or device embolization are quite low, probably less than 2%.
Brad, if again, trying to make the distinction between surgical left atrial closure, appendage closure, and transcatheter, if we think just about transcatheter approach, what do you think the future holds for these? Are we going to see, as we get more experience, more and more of these done in patients who might not be going to cardiac surgery?
Yeah, I mean, the prevalence of atrial fibrillation is huge, and it's growing as the population gets older, as obesity becomes more of a problem. So AF is getting bigger, and patients have a lot of comorbidities. So even if we have more advances in oral anticoagulants, there will always be patients that have relative contraindications. And as we get newer and better devices that make the procedure better, reduce the risk of thrombus related to the device itself, improving long-term closure success and acute procedural complications. As these devices evolve over time, the criteria I just mentioned to you will probably change. There's even thoughts that several years from now, maybe everybody who develops atrial fibrillation, closing the appendage will be a better solution than anticoagulants.
Interesting. I mean, it's hard to get patients to take anticoagulants, even the newer agents. Well, it sounds like a really exciting development, and thanks a lot for educating me and our audience, and thank you for watching. I hope that you'll stay tuned, because we've got a lot more on atrial fibrillation that I think is going to be very informative for you to know.